Good evening. My name is Mark Pakyanathan. I'm a consultant physician working at St. George's Hospital here in London. Thank you all for coming today. Today I've been tasked to at talking to you about antiretroviral medicines. This series of lectures have been primarily aimed at people living with HIV because knowledge about your condition and the medication used to treat HIV will help you better manage your condition. So today we'll be talking about antiretroviral treatments. Before I start, I'm going to just talk through what I'm going to cover. Firstly, how the virus behaves in the human body and how it affects it. About when to start medicines, when's the best time to start treatment. A little bit about the different drugs available. I won't go into too much detail, but primarily talk about the different groups of medicines that are available. A little bit about how the medicines work and how the treatments work, and also the importance of taking treatment regularly, but also some top tips on, if I wanted to be an expert patient, what would I need to do? What would I need to know in order to best manage my condition? So let's talk a little bit about HIV, viral dynamics and treatment. And all I mean by viral dynamics is how does the virus behave and how does treatment link with that. So just to recap a little bit from stuff we've heard earlier in the series of lectures, how does HIV affect the body? Well, initially when someone first picks up HIV, from being HIV negative, they become HIV positive, and this is a process known as seroconversion. And at this time, people can be ill with flu-like illness, where the body can become tired, have temperatures and fevers. A person can develop sore throats, a skin rash, or even diarrhea at the time when they're ill, when they first pick up HIV. And this usually happens some weeks after initial infection. As the person recovers from this, they go through a period of what we call latency, where they don't really exhibit any symptoms of HIV and they are much better, and a period of time when they may have no symptoms at all. And then as the immune system becomes weaker, as the virus multiplies and damages the CD4 cells, then a person might develop symptoms. And that could be symptoms of the virus itself, causing night sweats or fevers or swollen glands. But also it could be due to symptoms related to the complications of having a weakened immune system. And these are developing, for example, infections or certain cancers in some individuals due to a weakened immune system. And then finally, when the immune system is so weakened, certain significant illnesses can occur, significant infections, significant cancers, and this is when a person is said to be suffering from the acquired immunodeficiency syndrome. The important thing to remember that at whatever stage you've been diagnosed, even if you were diagnosed when you've developed AIDS, treatments still work, and there is still an opportunity to get better, to recover from this virus infection. So that's the important thing to bear in mind. So, various stages from the start, it talks about the start of the infection, seroconversion, progressing down to becoming severely unwell, but treatments can work at every stage. But the big message to take home is that the earlier you're diagnosed and the quicker treatment is started, the better off you are, because people tend to experience more complications and side effects as they become iller compared to people who start treatment earlier. So let's talk about the medicines, which is the focus of our treatment today. So there are many different antiretroviral treatments, and one of the things that used to confuse me as a junior doctor is all the different names. Some people call it therapy, some people call it medicine, some people call it drugs. Well, it's all the same thing. So when doctors talk about therapy, treatments, drugs, we're all referring to antiretroviral therapy or antiretroviral medication or antiretroviral drugs. All refers to the same things, which is the combination of medicines that you're taking. The other thing that you might hear your doctor or nurse talking is HAART, or highly active antiretroviral therapy. And really that just means the same thing. It just means the combination of tablets that you take to control HIV. So terminology is important, but it can be confusing, and we sometimes use confusing language, and I apologize for that, but it's the way it is. So, again, I put another acronym, ARVs. It's the other thing you've heard. That's the same thing, combination of tablets for HIV. That's all ARVs mean, antiretroviral medication. Well, really the take-home message is as soon as possible. So we have now quite convincing data from research studies that shows the quicker you start medication for HIV at whatever CD4 count, so even if your CD4 count is very good, over 500, you're better off if you start treatment rather than waiting. It may be delayed in some situations. So for example, if you become very unwell and your immune system has become very weak and you pick up an infection such as tuberculosis, your doctor might want to treat the tuberculosis for a number of weeks before introducing the treatments or before waking the immune system up. So they might want to control another infection that's come in before they treat the HIV and wake the immune system up. So there might be certain situations where your doctor may propose waiting to start. So do not be confused about this or worried about this because there might be certain situations where it is better to wait. There are certain situations, of course, when a patient may not be ready. So we might say we think it's best to start treatment straight away, but you may not feel ready, you may not feel confident or comfortable to start medicines that you know very little about, and really that is your choice. So the really important thing to remember is that never feel bullied, pressured or forced into starting treatment, but feel that you're an equal partner and that you're making the decisions together with your doctor, nurse or pharmacist when you're starting medication. So there might be situations, and you know we deal with many people from different walks of life in different situations. So if you have problems with your housing or lack of privacy or trying to integrate your medicines into your current lifestyle, it might be complex to do because HIV treatments do require treatments to be taken regularly. So integrating that into your lifestyle is important, and taking your views into account is something that we really value at the time of starting treatment. So, what antiretroviral treatments are there? I've kind of done a cartoon of an armory of people ready to fight. And there are a number of families, and there are 5 main families of drugs. So, and in each family there are a number of different medicines that one can use. So, the first family are called the nucleoside analogues, or the reverse transcriptase inhibitors. And basically, to keep it simple, I'm going to call them the nukes. And the nukes are very much used as part of the backbone of HIV treatment. So many patients will be on a backbone containing either abacavir or lamivudine, which is called Kyvexa, or a backbone of nukes called tenofovir or M-tricytidine, called Truvada. So many of you might be familiar with these drug names, and they are the backbones for HIV medication. In some parts of the world, different backbones are used, such as stavudine and lamivudine. And the nukes are a very important family of antiretroviral drugs or antiretroviral treatments, and most people taking HIV treatments have nukes in their treatment regimens. And really the nukes were the first drugs to be invented to fight off HIV. So the first ever nuke was AZT, so some of you may have heard of the drug AZT, and that was a nuke. The next family of drugs is the non-nukes, I call them, or the non-nucleoside reverse transcriptase inhibitors. And many patients will also be on a non-nuke, so they may be on drugs like rilpivirine, efavirenz, and nevirapine. So drugs like rilpivirine are combined with 2 nukes to form the drug Eviplera, which some of you might be on. And the drug efavirenz is combined with tenofovir and FTC to form a combination called A-tripler, which some of you may be on, which is a single tablet a day. So combinations of non-nukes and nukes can make up highly active antiretroviral treatment or combination of treatments. The third family of drugs, if we go down the list, the third red one is the PIs, I call them, or the protease inhibitors. And these drugs, the commonly used protease inhibitors are atazanavir and darunavir. And they're often combined with a drug called ritonavir. And the purpose of ritonavir is to boost the levels of darunavir and atazanavir up. So if you just took atazanavir or darunavir on its own, you might get quite low drug levels, and then taking a ritonavir tablet with them increases the level of the drugs in your blood, and that makes it more effective. The protease inhibitor atazanavir, I should add, can be used without ritonavir, so some of you may be on that. And finally, the next family are the entry inhibitors, and drugs such as enfuitide, which is an injectable, and only used in extreme cases where people are very resistant to lots of medicines, because it's a complicated combination, tablet medicine to take, or maraviroc, which is called a CCR5 inhibitor. They are the entry inhibitors. And finally, a family of drugs being used more and more frequently now as part of combination are the integrase inhibitors, and the common ones used are alvategravir, dolutegravir, or raltegravir, and these are just another family of drugs. So really, in summary, they are the nukes, which are often like the spine or the backbone, and then you might add a non-nuke to it, or you might add a PI to it, or you might add an integrase inhibitor to it, and often they're used in combination. Depending on your own individual circumstance, whether you've got resistance to different treatments, or maybe you have side effects to some treatments, your combination may be unique. It may not have nukes, it may have other combinations of treatments. So combinations of drugs using from these five families can help suppress the HIV virus in the body. So these are some of the things I've been talking about. So if we look over on the left, Kivexa, which has got abacavir and lamivudine, combined with a third drug, which could either be the non-nuke Sestiva, or the integrase inhibitors, or the protease inhibitors, will form a combination of therapy. So one of these, which has two drugs, with one of these, or one of these, will form a combination for any individual patient. Similarly, the other backbone, Truvada, which I talked about, which contains tenofovir and emtricitabine, can be used this way. Now, newer formulations, newer developments of these drugs are currently underway. So it is a field that's rapidly changing, and therefore having a doctor working regularly with people, treating people with HIV is very important, because HIV is a field that rapidly changes. You want to attend a center where there are many people with HIV who attend, and see a doctor that's used to prescribing the drugs and used to staying abreast with treatment changes, so they can give you the best advice. So the next slide is about how the drugs work. So I hope I haven't confused everyone, but 5 families of drugs, often with 2 nukes combined with one of the others, and really what these drugs do is interrupt HIV production. So really, if you imagine your body as once the virus comes in and it starts multiplying, the body is converted to a factory to make more HIV, in particular the CD4 cells, which the virus really likes. It loves CD4 cells. It goes into the CD4 cells and makes it to a factory for making more HIV, and that's why the immune system gets damaged, because the poor CD4 cells can't cope and they die off and they go down in number, or they get dysregulated, and the immune system becomes weaker. And so once this virus gets into your CD4, it takes it over and says, right, you're now a factory to make more HIV. So that's what happens. So if we think of a car factory, a car doesn't just magic itself. You make the body, you add the wheels, you put the upholstery, you insert the engine, you load it up with petrol, and then you wheel it out, and then it works. So similarly, when you assemble a virus, it's pretty much like assembling a car in a car factory. There are different stages that's needed in order to make a new virus. So I hope I'm not going to keep you with me. It's not that important you understand this in detail. If you just think about the car factory analogy of getting the body of the car made, putting in the upholstery, putting in the engine, putting in the wheels, loading the petrol and the engine oil, and then getting it moving. So if you stop any of those processes, you've got a car that doesn't work, a car that can't run, a car that can't take you anywhere. So just like that, with HIV, it's got to go through all the different phases of development in order for it to be a useful virus that can go on and cause damage elsewhere. If you stop it at any of the phases, you get these useless bits of protein that can't do very much, can't cause any damage. So if we think about HIV, the virus, at the top, which finds the CD4 cell, which it loves because it likes sticking to CD4. It's got like a magnet to metal. It looks for it and it sticks to it, and then it enters the cell, converting it to a factory to make more HIV. And the reason it needs to make more HIV is survival, because your immune system, even though it's being attacked by HIV itself, is fighting back. So the good news is our bodies don't sit back doing nothing. We are constantly fighting HIV. If it's in our bodies, it just fights them, destroys them, tries to get rid of them. But the virus fights back by making more, by going into a CD4 cell, making new HIV viruses. So one virus going into a cell and new viruses coming out the other end. The new viruses going on to new CD4 cells to make new factories for more HIV, whilst the body constantly trying to clear off the virus at the same time. So you get production of virus and destruction of virus. And that's what I'm trying to show here with these two tanks. If you're wondering what these two tanks are. The first tank, if you imagine water constantly being produced at the top of the tank, it fills up. But the bottom tap is the immune system, constantly getting rid of virus. So we've got production at the top, destruction at the bottom. And what you've got is a viral burden that's relatively well constant. So if you've got HIV infection and you're not on treatment and you're having your viral loads repeated, generally speaking, on average, it's roughly around the same level. It can vary around with the thousands or even the tens of thousands because you're dealing with tiny particles of virus that's actually in the same order, similar sort of levels. And that's because there's production, destruction, and it keeps the viral burden constant. But this burden, so the tank of water you're seeing there, is never ever the same water. If you think about it, if I'm constantly draining water out and I'm constantly topping out, the level is the same, but the actual water is new water after certain. Same with HIV. In any one time when you get your blood test with your nurse and you get your results saying your viral load is, I don't know, 10, 15, 20,000 this month, and if it was 10, 50, it's a different set of viruses that they're measuring, but that's because there's production and destruction. And really what we're doing with antiretroviral treatment or highly active antiretroviral treatment is we're turning off the tap of production. The drugs are so powerful, it just shuts down those factories of HIV production. And what you get is your immune system continuing to destroy virus, the virus dying off, the cells of virus dying off, and a reduction in the viral burden. So you reduce production and continue with destruction, and your viral burden falls. And in most cases, if people take their treatments properly and regularly, the viral level goes down to below detectable or undetectable, or is reported sometimes as not detected. And this simply means the level of virus is so low that the blood tests that we use don't really detect the virus anymore. It doesn't mean the virus is gone, it just means it's at a very low level. In the UK, in most centres, we say that's less than 40 copies of virus in 1 ml of plasma. So that's a low viral load. So less than 40 viral particles in any 1 ml of blood. So let's talk a little bit about viral load. So if your viral load was 10,000 in the first test tube, it goes down, let's say, to 20, and that's less than 40. But it just means there's so much less virus because of all the production, all those factories shut down. But it's still there at a low level. And the target for treatment is less than 40. So you've got to work with your doctor, work with your pharmacist, your nurse, to make sure you're taking your medication, get your bloods monitored. When you start treatment, you want to see the viral load going down, and you want to achieve a viral load of less than 40. Now, if it's not less than 40, then it's really important that you discuss with your doctor and that you have a plan to get it down and to understand why that isn't the case. So if you're someone out there who's on treatment and your viral load is not less than 40, and you've been on treatment for some time, over 6 months or so, and it's not going to undetectable or less than 40, it's really important that you have this conversation to find out why is the case. Am I on the right treatment? Am I resistant? Am I missing tablets? Am I finding it difficult to be adherent? What are my problems? How can my clinic help me? Okay. So what are the benefits of treatment? Well, we talked about destruction of virus and lowering the level of virus. We've talked about the CD4 count improvement, but we haven't really talked about that. But as a side effect, when you shut down the factories that produce HIV, if you think about it, new CD4 cells don't get infected by the virus anymore. And so there's recovery. There's recovery of your CD4 cells, replenishment. And often this results in an improvement of symptoms. If you're very ill when you're diagnosed with a low CD4 count and have a serious infection in your body at the time you're diagnosed, sometimes, when you start treatment, actually you can become iller. So in most cases, when people start treatment, they get totally much better. Their night sweats settle, their fevers go down, their weight increases, they feel stronger, and it's like they feel a new person. However, in some cases, when people are very ill, when they're diagnosed late, when they have other problems, when the immune system wakes up and finds out there are other bugs in the body, it goes a bit crazy. It tries to attack them all. If you imagine your immune system as a lion that fights off any enemies that comes in, but HIV has put that lion to sleep. And if you think of antiretroviral therapy as a stick that pokes the lion to wake it up, the lion wakes up and it starts seeing all of these bugs around, it can go a bit crazy. So some people find that when they start treatment, particularly in the first 3 months or so, their symptoms can get a bit worse. They can develop pneumonia or they can develop shingles. And this is a condition called immune reconstitution related illnesses, or IRIS. And these problems are seen particularly in people with very low CD4 counts when they're diagnosed. So another reason to get diagnosed quick, early, and get on treatment as soon as you can so you don't suffer these complications. But you know, if you're working with a good team, you can get through this difficult phase, and most patients do. And really, there's one other big advantage. So a lot of patients that I look after are really worried about passing the virus on to their sexual partner. And actually, the chance of passing on the virus to a sexual partner becomes incredibly low and very unlikely if you're taking treatment properly and your viral load is undetectable. So that's another huge benefit. Now, lifelong treatment for HIV is what's proposed, which is suppressive therapy to keep the viral load undetectable. And really, how that's achieved is by keeping the drug level constant. If you think about putting pressure down on something and something else trying to pull it up, if you keep your pressure down, things stay contained. But if I take my pressure up, things then start shooting up the way. So maybe I'm not analyzing that very well. Or even if for example, if there was a hole in a dam, if you're Dutch listening to this, a finger in a dam and water's leaking out, if I put my finger into the hole properly, it's totally tight and water doesn't leak out. But if I even pull it out a little bit, water starts trickling out. And if I take it off completely, water starts just gushing out. So similarly with the virus, if you're taking your medicines properly, if your drug levels are constant, it's like sticking a finger and just plugging the hole completely. There's no virus can escape. But if you start missing doses, if you start letting the virus level fall occasionally, it's like taking your finger out and letting virus leak through. And the more virus you let leak through, the stronger that virus comes and it can become resistant. So good adherence, keeping your drug levels is essential with HIV. And it is actually more important to be adherent with HIV medication compared to many other disease areas. Because the difference for example, if you suffered from epilepsy and suffered from seizures, is that, well, if you did suffer a seizure, obviously having a seizure could be serious for you. So I'm not belittling the importance of taking your epilepsy tablets. But if you didn't take your tablets for a while, you might have suffered from seizures for a little bit. And if you were safe during those times and came to no harm, but chose to then take your tablets carefully again, the seizures will stop again or be controlled. But with HIV medicine, if you muck around with your treatment, you may not notice anything bad happen to you, and the epileptic might have some bad seizures and bad things could happen. But for HIV, you might not even notice anything if your CD4 count is good. But then if you try taking your treatment again, it's not going to work because if the virus has changed, you could have become resistant to treatment. So importance of good adherence to treatment is essential because the enemy, the thing that we're fighting, the virus, is clever. It can change, it can mutate, and it can become resistant to medication. So it's something that we can stay on top of with good adherence. It's something that we can win on. So really, adherence and antiretroviral, ensure not too little, or really getting the right level of drug is important. So, and with antiretroviral medication, it has what we call a narrow therapeutic window. So taking too much can cause side effects. Taking too little, you could develop resistance. So keeping the drug levels constant is important. That means remembering to take your dose roughly around the same time each day. Now, this is more or less important for all of the medicines with HIV. But speak to your pharmacist or your doctor if your routine is unpredictable and you need to change to times which you take your treatment. Do talk to us about it. Nothing is off limits talking about, nothing is taboo, because it's better to get the right information about the combination you're taking, or maybe getting a combination that suits you, that maybe allows that. The other thing is, if we remember back, we talked about 5 families of drugs. Most people are on 2 nukes and 1 other drug, so 2 families of drugs involved. If you become resistant to any of the drugs in any of the families, often the others don't work as well. So if you think about it, very quickly a person with HIV who's failing treatment can run out of options, because if whole families of drugs are wiped out, you've only got 5 families, so it's important to try and preserve treatment options. So as best we can, it's better if you're struggling, if you're finding it difficult, if you're worried that your level of drug has been low for too long and your appointment's not for 4 months or 5 months, why don't you come in, have another viral load done. Don't let things get too bad before they can be salvaged, because you don't want to knock out a whole family of drugs, especially if it's something that you can be supported with. So we talk about patient responsibilities, but I think, how can I be an expert? Maybe the expert patients. Here are some of the things that you could do. Well, one of the things that you could do is to know the names of the drugs and doses. So if it could challenge you now, if you can close your eyes and name your drugs and the dose, if you can do it, you're really doing well. And I think that's a good sign of someone who knows their condition and knows how to manage it, is if you make the effort to learn the names of your drugs and the doses. This is particularly important if, for example, you need other treatments from a different doctor who may not be your HIV doctor, who then could be better informed about drug interactions. The second thing is, if you're in the UK, most of you will be registered with a general practitioner, but most of you will have your HIV medication from a specialist. So the GP may not have entered the names of your specific HIV drugs into the GP computer. So when they do prescribe the GP medication for you, it may not pick up dangerous or serious drug interactions. So one of the things to do is to make sure when you go into your GP and your GP is prescribing, is to ask your GP, have you correctly entered my HIV treatments onto your prescribing system so that drug interactions can be picked up? Because I want to make sure I don't get any treatment that's going to affect my HIV medication, or any treatment that could be made serious for me because of my HIV medication, because there are many drug interactions with HIV medicine. So one of the things you could do is to double check that with your GP, and I'm sure your GP won't mind, because it is, and if you know the names of your drugs and the doses, that you can double check that your GP's got the right information. Also, if there is any doubt whatsoever, most of your HIV clinics will have an HIV pharmacist or a telephone number you can ring to a nurse or a pharmacist to double check to see if you've got drug interactions. So look, I know my GP put the right medicines in, but I'm really worried. I've started this antibiotic or this treatment for my blood pressure. Can I just double check? And we will be more than happy to double check if there are any drug interactions with you. So these are good habits to get into. Thirdly, many people travel, many people go away, many people go away for weekends, stay with friends. It's your responsibility to make sure you've got enough medication. If you're going away for a long period of time, don't assume a delivery of medication may be coming. Double check with your clinic that everything is in order. If you're traveling, you might want to have some medicines in your hand luggage, or keep the medicines with you if that's possible, to protect yourself from maybe luggage getting lost, etc. So making sure you've got enough medication with you wherever you're going is an important priority. And finally, if you're having any problems at all, is talk to us, because your problem, however small, is important to us. Your question, however silly it might seem to you, is not silly to us. It's important to us, and we want to know about it. Because supporting patients in achieving good adherence, in managing themselves, managing their condition, is important to us, because ultimately it's better for you, but it's also better for us. It's less blood tests to do, less follow-up appointments. It's less complicated all around if we're communicating clearly with each other and working as a team. Finally, antiretroviral treatment is just one aspect of HIV care. We like here at St. George's to think that we provide holistic care. So we are not only looking after your physical well-being, keeping your CD4 count good, your viral load undetectable, managing any physical problems, but we have a team of counsellors, health advisors to support you through your emotional and psychological well-being. Whether that be problems with mental health, problems with just feeling sometimes life is not going anywhere, or feeling that sometimes perhaps having HIV is getting you down, or feeling sometimes that maybe having this virus makes it difficult for me to discuss my problems with other people. We're here to listen to you, we're here to talk to you, because holistic care is a cornerstone and pillar to long-term good health and well-being. And social problems, so patients with housing problems, financial problems, these are things that we're interested in wanting to support you with and help you with. So to conclude, we've talked a little bit about how HIV behaves in the body. We've talked about when to start treatment, which is basically as soon as possible. And we've talked about the small, odd situations where it might be delayed. And actually, I've just remembered now, another situation might be, what if your viral is already undetectable and you're not on treatment? And we didn't talk about this, but some people are what we call elite controllers who may not need treatment, but it's something that can come up in a discussion perhaps after the talk. So what situations might treatment not be required, but in most cases as soon as possible. How the treatments work, the 5 different families of drugs and how we combine them. The importance of good adherence, because if you knock one drug out, you might be knocking a whole family of drugs out. So keeping your options open is important with good adherence. And patient responsibility. What can you do to maintain your health, particularly around your medication? Making sure that you've got enough supplies, making sure that you're managing your self well, and there's going to be a session on side effects later and how to cope with them. And a little bit on communicating and being honest and open with problems that you might be having, however small or insignificant you think you are. Because ultimately, a patient doing well on treatment is a patient that we want to work with. And a patient who's not doing so well is a patient we want to know about. And that can be achieved by more open communication. Thank you.